My clock is telling me it's 10 and it's time to get started. So come on back in and let's hit the next segment of our agenda, which is a chance to hear about patient-reported outcomes, collecting them and using them to improve the quality of care that we're offering to the folks who we're delivering palliative care to. We know from the survey findings that were shared yesterday that a whole bunch of the provider organizations are collecting information from the patients they serve, patient satisfaction surveys, other patient-reported outcomes. We know from the information that was shared yesterday and also information from other projects that the plans also have a big interest in the experiences of their members. But we also know that there's been quite a bit of variation in the tools that have been used to gather this information, varying levels of success in getting information that's felt to be meaningful, and also varying levels of success in actually just getting enough information to inform our understanding of what patients and members are experiencing with the care that we deliver. We're at a very fortunate point in time in the field in that we have now available to us some rigorously developed instruments that we can use to gather information from patients and caregivers about their experiences. And so we save some time in today's convening to hear about two of those tools. We'll hear from Katherine Ast from AAHPM, the American Academy of Hospice and Palliative Medicine, about some patient-centered measures for outpatient palliative care that her organization developed. And also we'll hear from Rebecca Ong-Price and Melissa Bradley from RAND about a survey that their organization developed specifically for entities that deliver home-based palliative care. So we'll hear from both groups about the tools that they've developed. And Melissa, if you're here, I invite you to join in the group if you wish. And then we'll hear about these tools, and then we'll have about 15 minutes for some discussion to ask questions about the tools, about how they could be used, and also keeping in mind our specific population, the Medicaid population, the Medi-Cal population, and the extent to which these tools meet our needs or not. So we'll go ahead and hand it over to Katherine to start things off. And Rebecca, if you want to go off video until your presentation comes, that'd be great. All right, thank you, Katherine.
Thank you. Hi, everybody. I'm Katherine Ast, Director of Quality and Research at AAHPM. Can you all hear me okay?
Yes, you sound great.
All right. And next slide, please. Great. So I want to tell you today about some measures, the patient-reported outcome performance measures that AAHPM developed. And this was a really unique opportunity that was brought to us by the National Coalition for Hospice and Palliative Care, actually. So I sit on a quality work group there, and the RFP was brought to our attention, and we were very excited about it. To my knowledge, this was the first time that CMS offered this type of funding to medical specialty societies in particular through the macro funding. So AAHPM partnered with RAND and the National Coalition to put in a proposal. Next slide. So as I said, we partnered with wonderful RAND, wonderful coalition, and also the National Patient Advocate Foundation, because it was really important to us to have the input of patients, families, and caregivers from the very start. Next slide. So we took some time to put together a technical expert clinical user patient panel. And that included obviously experts, practicing clinicians, patients, caregivers, family members, et cetera, many folks together. And we developed 2 patient-reported outcome measures, performance measures in the areas of communication and symptom management. So the first one measures palliative care outpatients' experience of feeling heard and understood. And this was a concept originally conceived of by Bob Gramling, a researcher and clinician out in Vermont. And palliative care outpatients' experience of receiving desired help for pain. And both of these concepts were highly prioritized by the field beforehand and thoroughly researched and evidence-based. So we were excited to get started on this and talk to our teacup about how to go about specifying these two measures for practice. Next slide. So a little bit about our development process. Next. It was a very rigorous process, if you know RAND, and there was a literature scan, focus groups, interviews with patients and caregivers, meetings with technical expert panels, because not only did we have a teacup, but we had a smaller panel, a subset of the teacup for scientific questions and more technical issues, and cognitive testing with patients and caregivers as well. Next slide. And we had a very robust national beta field test that we're very proud of, using a web to mail to phone survey design. The test did require a vendor, and our vendor was RAND for the test. But the vendor was able to send surveys to over 8,800 adult patients receiving care from 44 outpatient palliative care programs across the US. So this is a good time to mention that these measures were specified or are specified for clinics, outpatient clinics. And that was on purpose because they're developed for MIPS and alternative payment models. However, we do hope that the measures get used by other programs in other settings, and we continue to specify and test them in other populations, settings, et cetera, in order to make them widely used. And Rebecca will talk a little bit about how we, the two RAND teams working on both of these projects, did our best to harmonize the concepts that are in both so they can be used together possibly, or at least we're in alignment with each other. And in total, 3,850 surveys were returned. We're very proud of the response rate of over 40%. And data from the surveys were used to establish excellent reliability and validity and finalize the measure specifications. I'll talk a little bit about that on the next slide. Or the one after that. So you can come back to these slides. The two slides have the measure specifications for feeling heard and understood and desired help for pain. And both of these two, the measure specifications can be found posted on National Quality Forum's website right now because they are undergoing review from the Geriatrics and Palliative Care Standing Committee. So they've already had their first round of review and discussion by the committee and passed, and were deemed worthy and recommended for endorsement. So we're very proud of that. And so the full specifications and NQF documents can be found on the NQF website. So feeling heard and understood is a multi-data element measure. And it consists of 4 questions, as you can see, with the denominator of all patients age 18 years and older who had an ambulatory palliative care visit. And the score is calculated using top box scoring. And next slide. Receiving desired help for pain is a bit simpler to calculate. It's the number of patients who report getting the help they wanted for their pain by the palliative care provider and team. So that was an important concept for the teacup as well, the provider and team, because palliative care, of course, is a team sport. And so that's a key component, as well as this measure in particular is trying to capture the shared decision-making between the patient and the provider, especially because there are trade-offs, as you all know, between relieving pain and also staying lucid, staying engaged, and there's a lot of discussion that goes on, and this measure would capture any and all alternative treatments for pain as well. Next slide. So test results, quickly, reliability and validity were excellent for both measures. Survey mode and proxy assistance are included as risk adjusters. And for heard and understood, there's an estimated sample size of 37 respondents is required for measure reliability. Next. And for receiving desired help for pain, reliability and validity again were excellent in survey mode and proxy assistant risk adjusters. And this measure estimated about 33 respondents are required for desired reliability. Next slide. So we received wonderful feedback both from and for the field. Next. This slide just highlights the partnership with National Patient Advocate Foundation, and these two individuals served on our teacup as lived to share their lived experiences, and they spoke up very well and added so much to our process. Next. Good quote by Rebecca Kirch. Next slide. So during our public comment period, we're very proud of the feedback received from 207 unique stakeholders. This includes organizations and patients and caregivers. So, and you can see that they're very, very positive feedback. The providers were likely to use both measures and feel that they get to the heart of what palliative care is about. So with an 83 and 72% very or somewhat likely to use from that group. And then patients also were very enthusiastic, with 87% of them very or somewhat likely to complete the surveys. And they're primarily excited about the opportunity to drive change. Next. A little bit about how to use the measures. Next slide. So many things here, as you know, quality measures, well, particularly patient-reported ones, assess how well patients' needs are being met. And of course, that is the most important thing. And we recommend that these are implemented as part of a larger quality improvement effort. Providers can use them to identify and advocate for resources. Payers can use them to reward and encourage those who are providing high quality care, and et cetera. Education is another big one. What kind of education is needed? And each measure, you know, depending on the scoring, can lead to certain education modules, both for providers and for patients. Because an issue that was brought up were, you know, patient expectations on pain relief, and perhaps if the scores are lower, that can trigger a education module for patients. Next slide. So this is a link to our website. We encourage you to please take a look at it. It's being maintained by the National Coalition, and it has everything you want to know about measure descriptions, journal publications, why and how to use the measures, and patient-centered approach, and everything. And here I might mention too that we are getting ready to unleash or unveil our implementation guide. So this guide was recently approved by CMS and includes many, many links to wonderful resources, as well as recommended survey administration procedures and measure scoring methodology, all put together by RAND. And I believe that's it.
Excellent. Katherine, thank you so much. That was really useful. And let me ask you two quick questions before we move on to the RAND survey. One is that these were developed for use in a clinic-based setting, but did I hear you correctly that it's okay to use them for palliative care delivered in other settings as well?
Yes, there's no reason not to use them in other settings. They will need to be tweaked a bit, you know, the specifications, but we developed them for any use. Basically, we encourage them to be tested in other settings. Yeah, they do require testing. If you're using them for accountability, we would require, or not require, sorry, we're not the ones that recommend testing in the setting.
Excellent. And my other question is, so these are four questions related to feeling heard and understood and one about pain. What if an entity wanted to ask additional questions, like would you recommend us or other aspects of the care they delivered? Could these questions be added into a larger survey, or are they really only designed to be used by themselves?
So again, I think flexibility is the key. They are designed to be used either individually as a pair, or, we hadn't considered adding them to other surveys, but Rebecca will talk a little bit about how these same questions, almost the same, are used in their longer serious illness survey. So it's certainly, there's a precedent already. And I also know of another group that is incorporating them into their longer survey. They're working with Press Ganey to do that. So there's no requirements or any restrictions on them.
Great. Hey, thank you so much. So I think we'll say goodbye to you for a few minutes, and we'll invite Rebecca and Melissa from RAND to come in and talk about the serious illness survey specifically for home-based palliative care programs that you all developed. So take it away.
Fantastic. Thank you so much for the opportunity to talk about this serious illness survey for home-based programs, which we really hope will serve as a complement to the AAHPM measures that Katherine just described. So next slide, please. So separate from the macro measures that RAND partnered with the National Coalition and AAHPM to develop, around the same time, another team at RAND was commissioned by the Gordon and Betty Moore Foundation to develop a set of patient surveys that are designed to assess the care experiences of seriously ill individuals. And there are two surveys in that set. The first, which is final and ready for use, and which we'll mostly be talking about today, is specifically designed to assess care delivered by home-based serious illness programs. In the second phase, we're also currently refining and testing a second survey designed for plans and payers that are responsible for the care of seriously ill individuals, regardless of whether they're receiving care from home-based programs or whether they're receiving it somewhere else. So responses to these surveys can be used in many ways, some of which Katherine just outlined, but specifically we were developing these surveys with the goal in mind of being able to calculate quality measures that can be used in quality monitoring and improvement and in accountability initiatives like some of those that CMMI described in the earlier presentation today. Next slide, please. So a quick bit of background on how we went about developing the survey for home-based programs. This should sound familiar based on what you just heard from Katherine, based on the process that the AAHPM measures went through. But in the very first step, we looked at all previous surveys that had assessed serious illness care, and we gathered a technical expert panel that included experts in serious illness care, heads of several serious illness programs, representatives of palliative care groups and health plans, as well as patient caregiver representative. And we sought their input about the aspects of care that were most important to evaluate on a patient survey for those with serious illness and receiving care from home-based programs. We then went and interviewed many patients, family caregivers, and providers from serious illness programs from all over the country to talk with them about the same thing. So the care they were receiving, the care they were delivering respectively, and which aspects of that care would be most important to assess on a survey for the purpose of improving care and understanding how care was going from the perspective of patients and families. Drafted up a draft version of the questionnaire based on that input, and then took it back out into the field to do what we refer to as cognitive interviewing. So went back out to patients and family caregivers and had them look at the questions on our draft version of the survey to make sure that they were written as simply as they could possibly be and they were clearly understood and measuring the concepts we intended. And then we conducted a field test of the final draft survey, incorporating all of this feedback among 32 serious illness programs. And I'll describe that more in a moment. But just to finish out the rest of the development process, we analyzed the survey responses that came in from the field test to come up with a final version of the questionnaire with input again from our technical experts. And one more click on this slide, please. Importantly, when we interviewed seriously ill individuals about their care in these home-based programs, and when we reviewed the content of the draft survey to make sure that the language was clear and so on, we made sure to talk to individuals across a wide range of sociodemographic and insurance coverage groups so that we could be confident that the survey questions made sense, and that they measured what was most important to a wide range of seriously ill patients, including those with lower literacy and including those on Medicaid. So next slide, please. So as I mentioned, we conducted a field test to test out a draft version of the survey. We conducted that test with patients from 32 serious illness programs across the country. And these programs had very different organizational homes. Most were based in hospices, but several were from health systems and some from medical groups. And they range from very small, so as few as 7 patients, to quite large, as many as almost 1,500. And to give you a sense of the patients who we surveyed just about 6,500 of them. And of the 2,263 respondents, 21% had less than a high school education, 10% were Hispanic, 10% were Black or African American, and 7% were on Medicaid, and about a third also needed the help of a proxy or family caregiver to complete the survey. Next slide, please. So we used the survey responses from the field test to finalize 2 versions of the serious illness survey for home-based programs. There's one full version and an abridged version that's designed to be used if the cost or time of administering the full version would be prohibitive. The survey versions are available on our survey website, which is shown here in English and in Spanish. And we have PDF of mail surveys, as well as scripts that can be used to administer the surveys by telephone. And in addition, our survey website includes our recommended guidelines for using the surveys. And those are listed here. So those guidelines describe the contents of the survey, patient eligibility criteria, so which kinds of patients should be surveyed, survey administration procedures, as well as information on how to score the proposed quality measures and adjust them for patient mix if needed. So there's more details on the website on each of these topics, but over the next several slides, I just want to hit some of the high points. So next slide, please. So the final version of the survey includes questions on 5 topical domains that our technical experts and patients, family caregivers, and providers had indicated to us were important aspects of serious illness care. And in the first domain, we ask about aspects of communication. So how often people from the serious illness program spent enough time with the patient, explained things in a way that the patient could understand, listened carefully to them, cared about the patient as a whole person, and made the patient feel heard and understood. So that question, as you can imagine, is very similar, and we did our best to harmonize with the AAHPM heard and understood measure. The second domain is the umbrella domain of care coordination. So how often people from the program seem to know the patient's medical history, whether someone from the program talked about the care the patient was receiving from other healthcare providers, all the medications that they were taking, and how to get help with everyday activities like getting ready in the morning or getting meals. The final question in the care coordination domain was whether the patient got the help they needed between visits from the program if they asked for that help. In the third domain, we asked about whether the patient got the help he or she wanted for symptoms. So the 3 symptoms we ask about are pain. Again, this one's similar to the AAHPM pain measure that Katherine described. And we asked about 2 other symptoms as well, trouble breathing and anxiety or sadness. And similar to what Katherine mentioned earlier, we ask about whether the patient got the help that they wanted for these symptoms, and we allow them to let us know if they didn't want help for a given symptom or they didn't want it from the program. In our fourth domain, we ask about aspects of care planning. So whether someone from the program ever talked with the patient about what to do in case of a health emergency. And we know that may be important to programs or plans that are thinking about the role of home-based programs in preventing emergency room visits, for example. We also ask about whether someone from the program ever talked with the patient about what was important in their life and what their healthcare options might be if they got sicker. And finally, the fifth substantive domain is support for family and friends. That's on the full version of the survey. And we asked those who had family members or friends involved in their care if the program involved those family and friends in discussions about care as much as the patient wanted, and if those family and friends got the desired amount of emotional support from the program. So in addition to questions regarding each of these domains, the survey includes 2 questions that allow respondents to provide an overall assessment of the care they received There's a 0 to 10 overall rating scale, as well as a question about their willingness to recommend the program to friends and family. There are also questions on the survey about respondents' sociodemographics, like their education, and about their functional and physical and mental health status, and whether someone helped them complete the survey. So those questions are designed to help characterize the types of patients who respond, and also, if needed, to adjust scores for patient mix. So next slide, please. So as I mentioned, there are two versions of the survey for home-based programs. There's a full version that contains 36 questions, and an abridged version that contains 21. And for reference, the full version takes about 10 minutes to complete, and the abridged version about 5 minutes. We really try to keep the language as clear and simple as possible, which helps people to complete the survey in a timely way. The primary differences between the full and abridged versions are that the abridged version leaves out some of the descriptive questions, like the questions about the number or type of visits that someone received, some of the questions about evaluating care, like the questions about support for family members and friends, and screening questions, such as those asking whether a respondent has a particular symptom. So in the abridged version, we replaced those screening questions with a non-applicable response. So in a question about, for example, if the respondent needed help or wanted help with pain, there's a non-applicable response that says, I didn't have pain. Next slide, please. So here we describe the types of patients that the survey is designed for and our recommendations for who should be included in the survey sample. So the survey was designed for adult patients who are currently receiving care from a serious illness program at home or in an assisted living facility. So it wasn't designed for patients who are living, for example, in a nursing home. We recommend that programs do keep in the sample patients who might not be able to answer for themselves. Family caregiver can act as their proxy in responding to the survey. And this was important to our team and to our technical experts for ensuring that survey responses include the perspectives of those with dementia or other cognitive impairments that might prevent them from responding for themselves. We also recommend that patients be enrolled in the program for at least 6 weeks at the time that they're sampled for the survey, so that they've had enough experience with the program to be able to answer questions about it. And we also recommend not sampling and surveying patients who are known to be discharged to hospice or patients known to have died. So this was not designed to be, for example, a bereaved family survey like the CATS hospice survey. Next slide, please. So here we describe the two recommended modes of survey administration that we tested in the field test, one of which contacts patients solely by mail, first with a pre-notification letter that lets them know that a survey is coming soon, and then with 2 mailings of the survey 3 weeks apart, with that second mailing sent only to those who haven't responded to the first one. In our field test, in which we administered a much longer survey, it was 57 questions long because we're testing lots of extra questions that we were not kept for the final version. This mail-only approach had an overall response rate of about 30% lower among Medicaid beneficiaries. The second recommended mode of survey administration is what we call mixed mode. It was first a pre-notification letter, then a mailed survey, and then a follow-up by telephone to those who hadn't responded. The field test response rate to mixed mode was 42.5%. And as you can see in the right portion of this chart, adding telephone follow-up is particularly valuable for increasing the response rate among Medicaid beneficiaries. So the recommended approach shown here reflects an optimal design. It's based on survey research about how to maximize response rate. Our highest priority, as I'm sure yours is hearing from as many patients as we possibly can. Of course, we recognize in real life, there may be time, cost, or staffing constraints that prevent organizations from using this gold standard approach. So while we recognize that not every organization that uses the survey will be able to pursue the full set of recommended steps, it may be possible to pursue some subset of them or modify some to be within budget and resource constraints. So for example, one could use telephone prompts between mailings to help boost mail response, even if administering the survey by telephone wasn't possible. And I should say that these response rates shown here were based on a survey vendor, the RAND Survey Research Group, acting as the vendor conducting the survey. Next slide, please. So once you have survey responses, scores can be calculated for each question that evaluates care. And those scores are only calculated among respondents when the questions are applicable. So for example, if a patient indicates that they didn't have pain or they didn't want help for pain, they're not included in the score for pain. We recommend using top box scoring to look at survey results. They reflect the percent of survey respondents who give the most favorable response. This top box approach has been used by many public reporting initiatives because it's intuitive and easily understood by many audiences. But of course, if your organization finds it useful to look at the full range of responses, for example, some like to look at the percent who give the worst responses to try to identify problems, of course, you're welcome to do so. Next slide. So finally, if an organization is planning to compare survey scores across programs or trying to track performance over time within a program that has a changing patient population over time, we recommend adjusting scores for factors that are not within the program's control, but that have been shown to systematically affect how people respond to surveys. So these variables include the ones that are shown here: the age, education, primary diagnosis of the patient, whether they needed a proxy respondent to respond on their behalf, aspects of their physical, mental, and functional health, particularly mental health, made a big difference in our survey in terms of just how favorably people describe the care. So we think it's valuable to adjust for that. Response percentile, which refers to how quickly after administration of the survey, people sent it back or responded to us. And finally, mode of survey administration, so that male versus mixed mode. If an organization is not able to do this, that's okay. We just need to bear in mind that some observed differences in survey scores might be due to differences in patient mix as opposed to true differences in care experiences. So given limited time, that's all I'll say for now regarding the serious illness survey for home-based programs. But next slide, please. I did want to take a moment to let you know about the next phase of our work in which we're testing a version of the serious illness survey designed for use by plans and payers. So we'll be conducting a field test of that survey later in 2022, and we're right now looking for plans that have at least 100 seriously ill enrollees, with at least some of them not receiving care in a home-based program. So like the field test of the survey for home-based programs, the field test for the survey for plans and pairs will be administered in mixed mode, mail with telephone follow-up. We're hoping to be able to add web to that mixed mode as well if it's feasible. The draft survey in question will be about 25 questions and available in both Spanish and English. And our grant from the Moore Foundation covers the cost of data collection and will supply any participating organizations with a report of their results at the end and a small honorarium as well. So just wanted to let you know of that opportunity, as I had the opportunity to join the sessions yesterday and heard that there were many organizations that were interested in collecting these data, and we would love to be a part of that if this upcoming field test would help to meet those information needs. So next slide, please. So if you're interested in learning more about the field test or about the survey for home-based programs, here again is the survey website, as well as contact information for our team. And with that, thank you very much and looking forward to all of your questions.
Wow, thank you. Thank you so much. That was super useful. And yes, great. You came on back, Katherine. We have a ton of questions here for you all. So let's get to them. First one for Katherine, for the question about, did you get the help that you needed with pain? Is that, what if the person didn't have any pain? Is it not applicable, or is there a way for them to answer that?
There is. We also have a question: did you have pain? Did you want help for the pain? So it's actually two pre-questions before the important one. And I want to just, as Rebecca just reminded me, we also did test web for these measures, and that was feasible and is a way that these also can be collected. Yes.
Excellent. Good to know. Another question for you: the time period for getting the 33 or 37 responses, is that like within a year, within a quarter, within 5 years? Some of our groups care for relatively small numbers of folks, and it might take a while, depending on the response rate, to get that many.
So it is within the past 6 months. And there is some confusion sometimes when you first look at it. The look back period is 3 months to enhance recall, but then the appointments could have been 6 months or behind, and the data is collected 4 times a year for MIPS. But in general with the whole program. Sorry, I'm probably going to confuse things more. I'll just stop there and say all this is outlined in the survey administration procedures, but yeah, it can be a little bit confusing.
Okay, all righty. Thank you so much. Rebecca and Melissa, I'm wondering, are there any guidelines about who could administer the survey? So can this be done by administrative staff, a volunteer, for the phone version in particular?
Sure thing. Melissa, would you like to address that?
Sure, I'd be happy to. Can you hear me?
Yes.
Okay, wonderful. Thank you, everyone. So these, actually, I oversaw the field test for both of these surveys, and we used professional interviewers to do that. That being said, I think that we recognize that, programs and organizations are often under constraint in terms of cost. The thing I would say is that regardless of who you decide and should administer the survey or will administer the survey, that they have some training on interviewing techniques, proper interviewing techniques, and there's lots of materials available for that, and that anyone who or any group of people who are administering it should do this consistently across interviewers. So you're making sure that you're eliminating the bias, the interviewer bias that can be introduced in survey data collection.
Great, thank you. For both of these tools, they're designed to only be completed once. So you administer them at a time of discharge, at time of 1 month into the program, 3 months into the program. At what point in time do you administer the surveys? And we'll go RAND first.
Sure thing. So we haven't specified the frequency with which the survey can be used. We do talk about care received within the past few months, the last 3 months on the survey for home-based programs. So what we envision is that programs might do this at a frequency that meets their information needs. So it might be, for example, once a year, but the same patient can receive the survey more than once because they're thinking back, the recall period is the last 3 months. We just wouldn't want it to happen so frequently that it became a burden to patients to respond.
Great. Do you have any recommendations there? Once is enough, or you really need to do it at least every 6 months, or not something that you examined at all?
So we didn't make specific recommendations on that front. I think from our perspective, we wanted to put the tool out to help meet the information needs of programs and of plans. And so if it's helpful to take a snapshot, for example, once a year or once every 6 months of how care is going for all patients who are receiving care from the home-based program, that seems reasonable to us. And we know that across various initiatives, different frequencies have been requested from organizations for patient experience surveys. But I'd be curious to hear what Melissa and what Katherine have to say about this as well.
Please.
Sure. So same here. We didn't specify. I think the way that it was tested specifically for MIPS, it would be once a year. But I think if the measures were part of a quality improvement program that required them to be taken more often, I think that would be helpful in evaluating the success of interventions. So there's no restrictions and not really a particular recommendation except for yearly for MIPS.
And this is Melissa. I would just, again, caution against the burden on respondents. We all know that response rates are going down, generally speaking, and we certainly don't want to prime people to be over-surveyed. So I think the programs or those who use it should just think carefully about what your plan would be and the reason for multiple surveys.
Excellent, thank you. Very practical question for the RAND team. Was the telephone follow-up a reminder to complete the paper survey, or was it you call them and you can take the survey over the phone?
So we developed a mixed mode design and we fielded it 2 ways. The first mode was simply a pre-notification with 2 mail surveys. The other was a mixed mode design, which meant that we sent a pre-notification, then a hard copy survey out in the mail, and then we went to phone to try and complete by phone the interview by phone if we did not receive a hard copy return survey. And Rebecca had shown that slide that showed the differences in response rates. What Rebecca referenced about getting on the phone to do prompting is sometimes something that organizations do to increase response without doing a phone interview. So we know that getting on the phone can be a costly thing to do. So one alternative would be to have individuals call people who received the survey and encourage them to complete it by mail and send it in. Particularly if you do this before a second survey mailing, you can learn if somebody disposed of the survey and resend it, or just alert them that you will be sending another survey. And we do find that phone prompting can help increase response somewhat, certainly not as much as trying to complete the phone interview when you have someone on the phone, but it is an option.
Great, thank you. Again, for the RAND team, can you speak more to the adjustments needed for mental health given the prevalence of those issues in the Medicaid population?
Sure thing. So we listed a set of variables that we recommend for patient mix adjustment if adjustment is possible, particularly in the instance in which programs are being compared to one another. And I highlighted mental health in particular because compared to physical health and functional status, which we also propose to adjust for, we found in our field test survey data that those with better ratings of mental health responded more positively. And that's consistent with findings that better health status and mental health is associated with more positive assessments on all kinds of, on many patient surveys. So we just recommend adjusting for that, particularly, for example, if you're comparing a program that has more individuals with greater mental health challenges to one that has fewer, to ensure that there's sort of a level playing field, that the results you're comparing are reflecting not that systematic tendency to respond one way given a certain mental health status, but rather really comparing the care experience that they're reporting on.
Excellent, very, very helpful, thank you. Really appreciate that there's two versions of the RAND survey, the abridged and the full survey. I think that many organizations, provider organizations that are surveying their members maybe have 3, 4, 5, 10 items in their surveys, that those that administer phone surveys at the plan and the provider side for this population find it's, oh my gosh, it's hard to keep someone on the phone for 10 questions. And the thought of a couple dozen, much less more than that, was a little bit daunting. Because of that, I'm thinking that some groups may be tempted to take the RAND survey and use a subset even of the abridged questions. So not even do the full abridged survey for very practical reasons. Can you comment on what that would mean in terms of the validity of the results or the ability to use them? Is it okay if that's all you can do, or is that just really not a good idea?
So first off, the survey is in the public domain. It developed it for the use of programs, plans, and other users who might find it useful to assess the quality of their care. So users should use it in the way that's most feasible and useful to them. That said, we generally recommend using the full content of the survey, either the full or the abridged, in the order shown in our surveys online. And that's to promote the comparability of survey responses across programs if you're trying to compare or look over time. And this is because changing the order of content on surveys can be associated with differences in how respondents answer questions. People are primed, for example, by questions that they've answered previously, and that can change how they respond to later questions. So to be as comparable as possible, we like to be as standardized as possible. But as we've been saying throughout, I think this whole discussion this morning, we recognize that there are feasibility challenges and preferences that sometimes lead organizations to do things a little bit differently. One thing I'll note is that survey research has shown that reducing the length of a survey, even quite a lot, is really associated with only very small gains in response rates. So really what we tried to do to maintain as high a response rate as possible was to make sure that the survey language was as simple as possible. And that we were using survey administration techniques like the mixed mode of mail to telephone and pre-notification letter that have been shown to achieve higher response rates. And that could sort of offset the length of the survey in terms of keeping response rates up. So as we mentioned earlier, in the full version takes about 10 minutes to complete, the abridged version about 5 in our experience administering it as a survey vendor. And we did achieve a response rate of about 42.5% in that mixed mode, even with this much longer field test version of the survey. So the summary answer is programs are welcome to use the portions of the survey that they find most useful to them. If it's possible, we do recommend using the full or abridged survey in their entirety, because we do think that a really notable response rate can be achieved with some of the survey administration procedures that we've recommended. Melissa, was there anything you wanted to add to that?
I will just say training your interviewers helps a lot. We find that we have very, very, very few people who break off a survey they begin. So if you are finding that you're getting a lot of hangups during the middle of a survey, you should look at the people who are calling and maybe provide them with some guidance on how to administer a survey. It's a rare occurrence. And I think most people, even though it may appear that 20 questions are a lot, when they learn that it's 5 minutes on the phone, are pretty willing to complete that. So despite the number of questions, be aware that the time to administer is actually quite low.
5 to 10 minutes sounds pretty nice. Hey, I can't thank you all enough. Rebecca, Melissa, Katherine, super useful. Thank you for developing these tools and putting them in the public domain and giving us this orientation to how to use them. Also, thank you so much for putting guidance up on the web so that folks can pull these down and learn how to use them well and all of that. So really appreciate the discussion, the materials, and really looking forward to seeing the publications about the findings and seeing, multi-region, multi-entity gathering of these data so that we can learn collectively and develop some benchmarks and see what we can do to improve the care that we're giving and also make the case for this care if we're able to show that it's the satisfaction is quite acceptable as is. So thank you all very much. I really appreciate it.